Hi. Hello everybody. Hi. I'm Dr. Colin Kingston. I'm with Tidewater Orthopaedics. Thank you for joining me tonight, and I have the great privilege today to introduce the Mako hip. Now, I've already given a talk to introduction to Mako, but I'd just like to recap a little bit on that talk that I've previously given. Mako Robotics was created to help enhance surgeons' ability to put in components for joint replacements, particularly in knees and hips, more accurately. The more accurate an implant is put in, the better it will work, the better it will function, and hopefully the better it will last. But additionally, it's designed to help improve the cuts that the surgeon has to make into the bone to put the implant in, again enhancing precision, but also limiting the amount of dissection or surgery that needs to be performed when you're putting the implants in. This can result in faster recovery for the patient, better function overall for the patient, less pain, and quicker recovery. So it's something that I'm very excited to talk about and bring to you today. Today's talk is going to be predominantly about the hip replacement version. This is one of the more newer versions of Mako Robotics. Mako right now has a partial knee system that came out first, then a full knee. Now it has a total hip application, and hopefully soon in the future, sometime maybe next year, shoulder replacement and spine application as well. So today's talk is going to be predominantly on the hip. Hip replacement and hip arthritis is probably not as common as knee arthritis, but it is very, very common, more so than probably even shoulder arthritis. It can be very limiting and debilitating. Most people with hip arthritis will present to me with groin pain, sometimes buttock pain, difficulty getting in and out of a car, difficulty getting out of a chair, difficulty with prolonged standing, and any type of pivoting or twisting. The typical things that you do preoperatively is, or before you even think about surgery, is try the simple things, rest, ice, compression, elevation, anti-inflammatory medication, activity modification, and sometimes physical therapy can be helpful to help try to improve your mobility, stretch the muscles around the affected joint, and improve your balance. But when people fail non-operative management, then hip replacement may be warranted, particularly if the patient has bone-on-bone arthritis. And you can see here in this screen right here, this person right here, it's a CT 3D image, shows bone-on-bone arthritis, particularly in that right hip. So here you can see a plain film version of it. Now, typically when you see a normal hip x-ray, there'll be a space between the cup portion of the hip, called the acetabulum, and the ball portion of the hip, called the femoral head. And that space, when you look at it in an x-ray, really isn't space, that's cartilage. And with time, typically the person's leg will shorten a little bit, and as it shortens, sooner or later the bone will eventually be touching the bone, and that's when you'll hear your orthopedic surgeon describe this as bone-on-bone arthritis. And when you have bone-on-bone arthritis and you fail non-operative management, then surgery is certainly something to contemplate. This particular patient, you can see there's increase in whitening of the bone, there's some cysts right here, and they're just not quite bone-on-bone, but almost bone-on-bone. Also, you can see here on the other side, this person had their other hip already replaced. So when a orthopedic surgeon does a hip replacement conventionally, they usually look at the x-rays. Based off the x-rays, they'll do something called templating, where they use a design that they put up on the x-ray, and with that they try to determine what size the implant will be as an estimate. They'll try to determine the best way to put that implant in, whether that implant needs to have a certain neck angle, this is the neck portion of the hip, and whether they need to lengthen the leg or keep it at the same distance. So this is very important. One of the problems with hip replacement surgery is getting the leg length accurate and getting what I call the soft tissue envelope around the hip in a good position. In other words, the muscles need to be taut, but not too tight, but they also not need to be loose. You don't want to put the implant in and have the leg slightly shorter, and then the muscles are not as tight, putting the patient at risk for dislocating their hip. A artificial hip, which I'm about to show you now, can consist of a metal cup. Sometimes that metal cup will have screw holes on the back of it to help secure the cup, particularly in somebody who doesn't have very good quality bone. But oftentimes, like this patient, if you go back to that other image, the bone quality is good enough to where you don't need to put screw holes in there, even though you can see an opening for a screw hole in that particular cup. So this is this is what goes in there, and then there's a liner, and the liner looks like this. It looks like plastic. It's made out of poly, okay? And for some implants, that liner can actually rotate and spin inside the cup and provide additional stability with the inner ball portion, the head, what we call the head, spinning inside that. That gives much greater mobility and stability to the implant. And very similar to what this looks like right here. And then this is called the femoral stem, which is this part right here that goes down the shaft of the femur bone. Okay, and again, there's different types of stems, but this one is a porous coated stem that the bone will actually grow into, where you don't need to use cement to help hold it in place. Putting these components in very accurately is very important for not only the stability, but to actually reproduce the patient's leg length and make sure that the muscles are the appropriate tightness to allow maximum function, but more importantly, also stability to prevent the hip from coming out. A natural hip, when the ball goes beyond the cup, there's a ligament that helps hold it in place, and that ligament is like a check rein. We haven't invented anything that ingenious, so we have to rely on the muscles being the right tension and the leg length being the appropriate length for that stability, but also the component position. If this cup, for example, was put in, instead of slightly what we call anteverted or facing forward, let's say it's put in retroverted, this patient then goes to sit up and move, theoretically that hip can then dislocate out the back. If the patient had an anterior approach and that cup is like this, and the patient externally rotates, in theory, if this is too anteverted, it can pop out the front. So this is what we want to avoid from a technical standpoint with this surgery. So what does Mako then do for us? Well, Mako does a lot of things. For some of you that have not seen my first talk, this is the Mako robot, okay? And it has an arm right here, a mechanical arm, that I can actually move, but when I go to do the surgery, won't let me make an error as far as cutting the bone. Here you can see another model where you can see the way the cup has to be put into the cup. Now, that can be off lots of different ways. I could put it in like that. I can put it in like this. How do I know exactly which position that should be in? Well, what the Mako does, the preoperative planning with the Mako, we get a three-dimensional CT scan, which we're showing right here. This three-dimensional CT scan then allows us to determine what is going to be the best orientation for this cup to be put into this individual's anatomy. Everybody's anatomy is a little bit different, and knowing that ahead of time is very helpful. That three-dimensional image really helps enhance the precision of which and how assured that the surgeon can be that we're putting this in within just a couple of degrees of accuracy. Very, very accurate. And that then will hopefully prevent some of the potential complications that can occur with hip replacement surgery. So this is an example of that. One of the things that we do intraoperatively with the Mako is we typically have a pointer that we map out and confirm what the 3D CT scan is showing us. And once we do that, then with the Mako robotic arm, for example, we can actually, what's called reaming, we can actually make this cup very symmetric to accommodate the metal cup and do it in a one-time swoop. Right now, the way you do it with conventional instruments is the surgeon has to ream a little bit, take a look at the cup, make sure he's at the right orientation, ream a little bit, take a look at the cup, make sure it's in the right position, and oftentimes is reaming 4 or 5 times to make sure that it's in the right position and is gotten down to the center, the hip axis, right to the center of where the cup needs to be. And that's very, very important. And a lot of times that's just by inspection and by the surgeon's experience as far as placement of where that cup is. There's some certain bony references that the surgeon will use to make sure that that cup is going in the right place. But even the most experienced surgeons can be off by a matter of multiple degrees doing that. So putting that in more precisely is what the Mako allows us to do. Also, by just reaming it once by using the robotic arm, it saves time with regards to multiple reamings and also helps prevent surgical error intraoperatively. The other nice thing about the Mako that I think is really neat is leg length. When the surgeon is putting in a hip replacement and he's putting the stem, there's the neck length, the length of this ball right here can change. And that can lengthen the leg or shorten the leg depending on how it feels to the surgeon when they put it in. And a lot of that is already templated a lot of times preoperatively, but ultimately it depends on how stable the hips is when you trial it with a trial stem. So when the surgeon puts a trial stem in, he'll actually trial it, he or she will trial it to make sure that it feels good, that it's stable, and that the hip won't pop out of place. Now with the Mako, what it does is not only allows us to do that, but it also verifies that we get the leg length equal to what we had already measured based on the patient's either other hip or what we had previously templated. So here you can see the patient had already had another hip replacement. Go to the other image, the plain film. You can already see the patient already had an image. And what we did here is we already put in a ghost implant and templated what we think this should be to match the patient's leg length to the other side. So this has already been done. So this is not the implant, but this is actually the plan, and this is actually a real implant that was put on the other side for this patient. So it allows the surgeon to go ahead and do this not only preoperatively, but intraoperatively, to determine if we're going to match the leg length that we were set out to do to match the other side. So it really helps enhance the surgeon's ability to not only get it right, but get it incredibly accurate. And again, this will not only enhance the patient's ability to walk without any pelvic obliquity, in other words, one side high, feeling higher than the other, but get back to a normal gait, which then decreases the stressors on your lower back if you're walking in a more natural gait. So these are some of the advantages that this system has. And it's something that started in 2010, the hip, is that right? 2010 is when they started this hip design, and now there's been over, I think, 65,000 hip replacements that have now been done using Mako robotics in the United States over the past decade. And it's something that we're really excited about here on the peninsula to be the first group in the region to offer this type of technology. And I think at this point, and I think last time, we opened this up to a questionnaire, and I think that for patients coming online and asking questions, and I think that was very fruitful last time. So I think we'll just open that up again to people out there that are watching this video right now to ask some questions, because typically what you're asking will not only be helpful to yourself, but usually somebody else who's also watching this Facebook Live lecture.
All right, Dr. Kingston, the first question is, where is the incision?
So where is the incision? So the incision just depends on surgeon's preference. There's lots of ways to do hip replacement surgery, and I've done them every way imaginable. There's one to go directly in the front, which is called the direct anterior approach. It's also called the jiffy hip approach. There is a anterolateral incision, which is just slightly to the side of the direct anterior approach, which actually is becoming more and more popular among surgeons for a multitude of reasons. And then there's the direct lateral approach right here on the side, which goes directly lateral. And then there's the posterior approach, which now has been modified to what's called a mini posterior approach or a direct superior approach, which is really what is happening right now in a lot of literature, and that's gaining actually probably some of the greatest popularity for a multitude of reasons.
So it's not always an anterior incision?
So no, it's the answer. The question is it always an anterior incision? The answer is no. It really depends on the surgeon and the surgeon's preference as far as what approach they use. And I encourage everybody to ask their surgeon the advantages and disadvantages of the approach that surgeon uses. There are advantages and disadvantages to every approach.
All right. Does using the Mako cut down on recovery time?
So, can people hear those questions, or should I be repeating them, do you think?
People can hear me saying it for sure.
Oh, okay.
Yeah.
All right, so does the Mako hip cut down on recovery time? In theory, it does, and in some studies, early studies looking at comparing Mako robotic surgery to more conventional surgery, there is a faster recovery.
All right. What type of anesthesia do you use?
So the anesthesia depends on a multitude of factors. There are some new anesthetic techniques that can try to do a block to some of the gluteal muscles and some of the muscles around the hip that have been very effective. Some surgeons prefer spinal anesthesia, where they numb up from the spine down. But I generally have most of my patients undergo general anesthesia, and that has worked really well for me. I use a lot of local medication in the area, and again, that's worked very well for me for hip replacement surgery.
All right. Is this the same as the jiffy hip?
Is this the same as a jiffy hip? No. So the jiffy hip is just a term coined to describe the direct anterior hip approach. The direct anterior hip approach has been around for a long time, but it's been popularized in the last 10 to 15 years because it was touted when it first came out to be less invasive. You're not releasing as many muscles, although the blood loss was slightly higher because there's a least of vessels that you have to go through to do the anterior approach. But one of the reasons why it's not universally accepted by all surgeons is that the neurovascular bundle that goes to the leg, you're limited by the extent of that excision. So if one of the problems that can occur sometimes, for example, when you're doing a hip replacement, is the surgeon, when he's putting down the stem into the bone, can crack the bone right here. Now, if that crack is just right here at the top, it's generally an easy fix. The surgeon can put sometimes a very thick suture around it, or put a metal cable around it to hold it in place. And to be quite frank with you, it doesn't really change the outcome or course for that patient. And that happens about 4% of the time. However, sometimes the surgeon, when putting this in, can crack the bone go all the way down, much further below this bone, and it's very difficult to fix that through the anterior approach. You're limited now by the neurovascular bundle, and oftentimes you have to make a separate lateral incision to fix that bone. And that does change the weight-bearing status for that patient with a hip replacement. So again, the jiffy hip is just a term used to describe the approach to the hip, but it's not this technique. This technique is Makoplasty or Mako Robotics, and it's very different. Most people that do the anterior hip don't use or don't have the ability to use Mako Robotics to perform that hip replacement operation.
After a hip replacement using the Mako, do you need to have inpatient rehab?
So, no. In fact, hopefully by doing less dissection, less surgery, you don't need to go to rehab. Without using the Mako, I can tell you that my practice over the past 20-something years has really evolved. Where back 20 years ago, it wasn't uncommon for 20 to 30% of my patients going to a rehab center. Now I would say it's probably about 2% of my patients need to go to a rehab facility, and this is without using the Mako. And that's been just in changes in technique, less dissection, and not releasing as many muscles as we used to, and limiting the amount of dissection, which I think has really improved it. But with Mako Robotics, hopefully by improving the precision, by increasing the accuracy of implant position, and less dissection, I think there'll be a lesser need for going to rehab, even less than 2%, which is what my practice is right now for the past 5 to 10 years has been.
All right. Would you please tell them where you work and where you operate?
Okay, so I currently work at 3 distinct areas. I work at the place called the Careplex Orthopaedic Ambulatory Surgery Center, which we're actually now standing right in its lobby. This is an ambulatory surgery center where back in 2016, I was one of the first surgeons to do outpatient total knee replacement surgery here using striker navigation, which is just a notch below the Mako as far as putting in components in very accurately. And since that time, I'm doing more and more outpatient total hip and total knee replacements here at the center. Right across the hall in the orthopedic hospital at Centera Careplex is where I do the majority of my joint replacements. I also do operate also and affiliated with Centera Williamsburg Regional Medical Center, where I do joint replacements there as well as some outpatient procedures as well.
And what's the name of your practice, and which of your partners are using Mako as well?
So my name of my practice is Tidewater Orthopaedics. We're one of the oldest practices here on the peninsula that was started actually by our founder, Dr. Jim Phillips, I think back in 1972, when he got done serving the United States Navy. And several of my senior partners who now are retired, one served in the Air Force, the other one served in the Army, all joined him. And so it's Tidewater Orthopaedics. As far as my partners that are currently actually certified, you have to go through a certification process to be able to use Mako. Currently it's myself, Dr. Kingston, there's Dr. Payne, there's Dr. Higgins, there's Dr. Sablon, and there's Dr. Pelton that are currently using the Mako.
Is this the Mako surgery? I'm sorry. Is the Mako surgery about the same as the one available 5 or 6 years ago?
So is the Mako surgery now the same Mako surgery that was available 5 to 6 years ago? And the answer is no. The Mako surgery that was available on the peninsula 5 to 6 years ago was geared towards partial knee replacements. There's software programs that have to be purchased, and the robot has to be able to handle and have certain instrumentation to be able to do various joint replacements. So we were one of the first to be fortunate enough to get the ability to do total knee replacements using the Mako, and now total hip replacements using the Mako. And once again, I can't stress the excitement about hopefully being one of the first to get to use the total shoulder replacement application as well as spine application in the near future.
All right, this is a great question. Will I be able to turn through a golf swing after recovery?
Yes, you'll be able to turn through a golf swing after recovery. In fact, even using conventional instrumentation, I have most of my golfers going back to playing golf and hitting golf balls somewhere between 2 and 3 months. I've had a few very avid golf players go back as soon as 1 month, but I do recommend 6 to 8 weeks before you hit a bucket of balls, for example, for a lot of my patients.
Will it help his drive?
Yes, so it can help your drive, because oftentimes when you have arthritis, what happens is, you have to think about it, the ball portion of your hip is starting to, as cartilage gets worn out, your leg starts to shrink, go in and shorten, and then you develop bone-on-bone arthritis, and then it gets socked in. And so your motion, your pivot and twisting while you're hitting the golf ball is limited, and the amount of backswing and amount of energy you can generate to hit the golf ball then becomes limited. When you have a hip replacement, like the one here that I'm showing you here, you have incredible motion of your hip that you didn't have prior to the surgery, which will allow you to get your hips and pivot through as you hit a golf ball. And so it's not uncommon for a lot of my patients that have their hips replaced that tell me that they can start hitting the ball similar to what they were able to do 10 to 20 years earlier.
All right. I use a tether incline board for back pain. Will I still be able to use that after Mako hip surgery?
So can you use a tether board, which for people that aren't familiar with that, it helps you go sometimes upside down and stretch your spine, particularly people that have duodenal disc problems, bulging discs, things like that. It can be very helpful. And the answer is yes. As I tell all of my patients with hip replacement surgery, there's only really 2 things I don't want you doing, and that's jumping out of perfectly good airplanes, and so parachuting and I don't want you bungee cord jumping. But other than that, most of my patients can get back to doing everything they want to do without any limitations.
All right, how long before I will be cleared to drive?
So driving requires that you have to, number one, be off of pain medication. Most of my patients with hip replacement surgery are off their pain medication somewhere between 2 and 6 weeks. So that's the first criteria. The second criteria, you have to have the reaction time to be able to go from the gas to the brake. If you don't have that reaction time, you can't drive. So the earliest I'll have or permit anybody to drive generally is about 2 weeks after the surgery, but 1 month is probably about the average time that my patients can get back to driving without any concern. I generally tell my patients, who's going to be most critical of your driving, your ability to hit the brake when you need to? Well, a loved one, right? Someone in your family. So go to an empty parking lot, you have to pass their driving test. You pass their driving test and you're off pain medication, you can start driving again.
Okay. Is the reason for not using the Mako robot with the anterior approach because you see less in the area? It's a visual problem?
No, so the Mako robotic surgery can be done through any approach. So that's a very complicated question, but it's, in my opinion, somebody who's done the anterior approach and has done a lateral approach and has done a posterolateral approach and now a direct superior approach, I believe that you can get better visualization in mapping out, when you're mapping out the anatomy through a posterior approach than you can through the anterior approach. But a lot of my colleagues and partners that do the anterior approach will tell you that they can map it out just as well doing the Mako through the anterior approach. So again, the approach won't limit the ability for that surgeon to use Mako. The only limitation is if that surgeon has access to the Mako that has the capability of doing a total hip replacement or not.
Would you consider doing a bilateral replacement using the Mako?
So would I consider doing a bilateral hip replacement through the Mako? The answer is yes. It would depend on the patient, and comorbid factors. To me, oftentimes it's not so much the technical aspect of doing both hips or both knees at the same time. So from my standpoint as a surgeon, it's actually fairly easy. I think what really matters is is the patient healthy enough to withstand doing both at the same time. There's many studies out there suggest that when people have both hips or both knees done at the same time, that in general, most patients don't do as well if they had them done in a staged fashion. And typically what I have developed over the past decade is to do it exactly that way. Patients that really want to have them done as soon as possible, I do them as soon as 2 weeks apart. And I find that 2 weeks is just enough time for patients to really trust that extremity that has been operated on 2 weeks earlier. And I do that probably about 60 to 70 times a year in patients. So that's what I prefer to do 2 weeks apart for both hips and knees.
If there is a blackout during surgery, can the surgeon take over for the robot?
Yeah, so every OR has a generator backup. So if there's a backup, we actually don't lose electricity to continue to operate on that patient. The more important is the anesthetic machine keeping you alive and your airway patent when you have a blackout. So every OR has a backup generator to help you. So the Mako would not, that would not be a reason or call for not being able to use the Mako. I guess really honestly a better question is what if the Mako breaks while I'm operating, and can I then switch gears and use conventional instrumentation? And the answer is absolutely yes, and that should not be a problem. As far as I know, and I'm unaware of any cases like that, I have a Stryker representative right here with me. There's been no known cases of the Mako actually breaking down and not being able to function during an operation. And it's been used hundreds of thousands of times, not just 65,000 times with the total hip, but over 100,000 of times with knee application.
And the robot's not doing the surgery, you're doing the surgery. in a
Right.
robot.
So this is a question that I also was asked of me the first introduction to the Mako. The actual surgery is done by the surgeon. What the robotic arm does is it prevents me from making error. So when I'm using instrumentation, for example, and I'm reaming the acetabulum, I could push too hard in theory, pushing so I go actually into the center and create a soft spot right into the center of that acetabulum, which then would make putting the cup portion into this hip a little bit concerning, because if the cup is undersized, it can then in theory, go into the pelvis, which is called protrusio or acetabular protrusio, and you want to, obviously that's a disaster on a very high level. So what the Mako robot will do is prevent the surgeon from making that potential soft spot right in the center. When surgeons do have that soft spot, which sometimes does happen, the surgeon has the ability with a multi-hole cup to use screws to help fix it so that doesn't happen, so that the cup does not go into the pelvis. But what the Mako robot does is prevent the surgeon from pushing too hard, even in soft bone, and going too far, violating what we call the medial wall of the cup portion of your pelvis.
On average, how long does it take for people to get back to work?
On average, I would say for right now, for most of my patients, it's about 1 month. I've had some patients go back to work as early as 2 weeks, but 1 month is probably my average. Now, again, it depends on the line of duty. I do have patients that are construction workers that work on roofs and things like that, and their balance is going to be of an utmost importance before I'd let them go back to work. So I think that's somebody who I'd probably have out of work for approximately 2 months' time until they can prove that they can balance with the physical therapist on simulated roofs with that physical therapist. So we call that work rehabilitation or work conditioning, that the physical therapist will work with them on before we allow them to go back to work.
Is it possible to wait too long for a hip replacement?
Yeah, so I think that there is. I mean, and I think that's true also for knee replacement surgery. I have a fair number of patients that wait too long. And what is waiting too long? Waiting too long is when you allow your hip arthritis to impact your ability to stay active and healthy. If you find yourself gaining 19, 20, 30 pounds, 40 pounds from being inactive, you're finding that your diabetes now is becoming a little bit less controllable. All these things are putting you at higher risk for potential complications that wouldn't have occurred if you would have had it done while you were young enough and healthy enough still to have it done. Now the caveat of that is this: there's a window of opportunity that is ideal to have joint replacement. Ideally you have bone-and-bone arthritis that has failed non-operative management, and that you're young enough and healthy enough to have the surgery. And that varies for everybody. So waiting too long is when it starts impacting the quality of your life. You start becoming more inactive. You start seeing the pounds come on. Your diabetes, if you have it, is no longer well controlled. These are all red flags that you should get seen, get evaluated, and get the diabetes weight off and have your joint replaced.
What is the complication rate after using the Mako?
What is the complication rate after using the Mako? Well, the complication rate is less for dislocation and less for malposition of the implants, because the Mako allows us to put the implants within 2 degrees of accuracy, which is excellent when you think about most hip replacements. You're shooting for somewhere between 5 to 10 degrees of accuracy, and on leg length, you're shooting for within 5 millimeters of the other leg. Whereas Mako allows you to get within millimeters of accuracy, less than 5 millimeters of accuracy in leg length, and within a few degrees of accuracy of component positioning. So this is not only for the short term, but also for the long term, because if the components are in more accurately, in theory, the weak link of any hip system is the plastic, and that's what wears out. And when that wears out, then the metal implants become loose in the bone, and then they become loose, that's when you need to have revision surgery. So we call that aseptic loosening, which means that there's no infection causing that loosening. The number one cause of early failure, though, is infection, and an infection that causes loosening of the implant. But late loosening or late complications is due to this plastic wearing out. So the plastic will wear out much faster, for example, if the cup is put in, let's say, fairly vertical. Now you have this plastic that's loading right here constantly. It's going to wear out much faster than an implant that was put in at the ideal position, and it has a more symmetric wearing out of that plastic liner, if that makes sense.
What is your infection rate?
What is my infection rate?
Yeah.
So for total hip replacement, and I don't want to jinx myself, I've never had an infection, so my infection rate is 0% for total hip replacement. My infection rate for total knees is about 0.2%, which is very low. The national average is around 1% or slightly under 1%.
And that's special about the COASC as well, right?
Yeah, so is that special about the COASC, or actually even the orthopedic hospital right across the hall? And the answer is yes. One of the things that when I got out of the Air Force in 2003, I always felt like it was important to have a hospital that specialized and had specialized teams that could help you as the surgeon. Me as the surgeon, I view myself as a quarterback on a football team, for example. But any quarterback can get sacked and have bad outcomes if you don't have an offensive line or a team surrounding you that is making you look good while you're operating. And from 2003 to 2007, 2008 timeframe, my infection rate was close to the national average. My complication rate was close to the national average. And I really strove for myself personally that I wanted to not be the average. I wanted to be in the top 1% or the top 10% in the country for outcomes for my patients. And myself and two of my partners, Dr. Peen and Dr. Campbell-Caro, sat down with various hospital systems, and we found that Centera was the most amenable to our ideas of creating an orthopedic hospital where we have specialized teams. That's all they do is orthopedics. They don't do anything else. They don't do vascular procedures. They don't do general orthopedic surgeries. They don't do OBGYN. All they do is orthopedics and focus in on orthopedics. And we convinced the Centera healthcare system to build us the first orthopedic hospital in the region. And this would be mirrored at a much smaller level, microscopic level, from the Hospital of Special Surgery in New York, which is touted every year as one of the best hospitals in the world. And all it is an orthopedic hospital in New York City that has some of the best outcome data for total joints and infection rate. And we said, let's not reinvent the wheel. Let's mirror what they're doing up in New York, here in the Hampton Roads area, in the Tidewater area, and try to get our results just as good as theirs, if not better. And right now, I believe the infection rate that was recently posted at the Hospital of Special Surgery was 0.2% for their joints, and ours is 0.1% for the past 10 years. So we actually are beating one of the top hospitals in the world on our infection rate. And again, this is not by chance, it's by design. You have specialized teams that's all they do is orthopedics. We implemented getting the best technology, the best instrumentation for our patients. We started using waterproof dressings called Aquacell dressings that have silver in it, which is a natural antibiotic. Some hospital systems have now started adopting this dressing, for example, have seen their infection rates halved, cut in half by using it. We used it mostly for the waterproof effect, but certainly this is one of many factors that has allowed us to have one of the lowest infection rates in the United States.
So how do you feel about outpatient surgery?
So outpatient surgery for total joints, if I would have given this talk 20 years ago, I would say never in my life will I see outpatient total joints being done. Back then, 20 years ago, we used to admit patients sometimes even the day before we did their surgery. They would spend at least 3 days in the hospital, sometimes a week, and more than half of them were going to rehab facilities. Blood clots, even bed sores, pneumonia, being in bed with a machine that would move your knee, for example, was the wrong plan, the wrong post-operative plan. Getting people up, getting them moving helps decrease pneumonia, blood clots, infection, and we now have discovered that by doing and implementing some of these post-operative protocols, by getting better anesthesia preoperatively, preventing the pain before it starts, by using better techniques surgically and better implants, we've been able to now, and using computers and now robots to help put in the implants more precisely. I do believe that as my practice continues to evolve, I would say close to, this week, for example, I did 4 knees yesterday. I'm doing 2 knees outpatient tomorrow. That's about almost 1/3 of my practice now is being done almost on an outpatient level. I wouldn't be a bit surprised in the next 2 to 3 years that close to 50% of my practice will be outpatient, and I wouldn't be a bit surprised if 8 to 10 years from now we're going to have to justify to insurance companies why patients need to be admitted at all. And that, in fact, that's already starting to happen. Our results are so good for our outpatient cases that insurance companies want to save the costs of doing total joint replacement, and it's much more cost effective to do it in an outpatient setting. But we couldn't do this in an outpatient setting unless we had these specialized teams to really ensure that we're not putting our patients at risk by sending them home that same day. And this is over the past, I've only had 4 years experience doing outpatient total joint replacements, but this has really improved to the point where now I'm broadening my patients' indications that can be done on an outpatient basis.
At what age should you have a replacement, ideally?
So the ideal age is you have to look at the longevity of the implant. Implants that I put in over 20 years ago in the laboratory were lasting about 18 to 20 years. I now have over 20 years experience and can tell you that 18 to 20 years is about right for the implants that I was putting in back then. Implants that we're putting today or in the lab are lasting anywhere between 25 and 33 years. So if you look at the average lifespan of a woman, for example, in the United States, which is around 81, 82 years, men it's around 73, 74 years, you want to do a replacement once, and that will be their first and hopefully last operation they need to have on that joint. So I think it's very reasonable to consider people as early as their 50s to consider having joint replacement if it's truly bone on bone and interfering with their quality of life. Now, having said that, have I done patients much younger? The answer is absolutely yes. There are exceptions to all rules, and that's why these are just generalization rules, not absolute rules set in stone. My youngest patient I ever did a hip replacement on was 13 years old. She had a disease called juvenile rheumatoid arthritis and was placed on high-dose steroids. And what happened was the bowl portion of her hip not only died, but it evaporated. So she couldn't walk on this portion. So this was what her hip looked like, basically on her cup. And so she couldn't walk because there was no femoral head that she could walk on. She couldn't sit comfortably. She couldn't move her legs comfortably. She was miserable. So the options that I had for a 13-year-old was to fuse her hip to the socket like that so she can't move her hip at all, which would affect her ability to have relations with a man later on. She was a female later on in her life, and or deliver a baby, and never mind other factors, just being able to function in sports activity-wise. I did her hip replacement, and at her post-operative visit 2 weeks later, she asked if I can do her other hip the next day because her pain was that much improved. And she was the first patient that I did the other hip 2 weeks apart, and she's now, this is 20 years ago, so she's now 33 years old, and her hips are still doing very, very well. So there are exceptions to all rules. I think that if you have the disease and you have bone-on-bone arthritis and you fail non-operative management, hip replacement, regardless of age, may be the appropriate procedure for you.
All right. Do you have any available appointment time?
Yes, I accept new patients as well as established patients. You can make the appointment at tidewaterortho.com, and it sounds just like it does. And our number is 757-827-2480. I do see patients both in the Williamsburg and Hampton offices, so whatever is most convenient or closest to you would be appropriate. Additionally, I currently have 2 physician assistants that work with me, and soon to have my own physician assistant work with me. His name is Ben Gensler, and my other physician assistant is Amanda Watkins. They're both excellent, and you can make an appointment with them if I'm not available. So we have many points of access to come in and get seen. I encourage that if you have problems with your hip, you've been putting up with it for a while, you might have seen maybe a little bit of weight gain, and or your diabetes or other medical conditions are starting to exacerbate because of your inactivity, I encourage you to make that appointment, get evaluated, get seen. Every now and then we'll see patients that will come in, for example, with bilateral hip pain, only to discover that it's not their hips at all, it's actually their lower back, and the nerves going to their hips are causing the pain. So sometimes what we may think might be hip arthritis may actually be something different, and it may be something like what we call lumbar stenosis, where the openings to the nerves exiting your lumbar spine are being squeezed by bone, and that can cause hip, sometimes upper thigh pain that can mimic arthritis. So part of the whole process when you see either myself or one of my physician's assistants is to make the diagnosis. Is this arthritis? Is the arthritis the source of your pain, or is there something else going on that may be causing your symptoms?
All right, in the first days or weeks, what is the greatest risk to successful recovery?
So the question is, immediately after the surgery, what is the greatest risk to success of the surgery? Well, the biggest risk that some surgeons worry about, is obviously, and sometimes it's outside of our control, is a blood clot that can travel. So for the first 3 to 4 days, or sometimes even first week, it's not so much a blood clot that we worry about, it's a fatty embolus. Basically fat can sometimes be embolized, get into your bloodstream and travel, and can cause pneumonia, can cause a stroke, can cause a heart attack. And these things, even if you're on blood thinner, are outside the control of the surgeon. The good news is they are extremely rare. Other things could be blood clots, and blood clots I have found to be much less likely now over the last decade of my practice than the first decade of my practice, largely because of, I don't believe necessarily because it's the blood thinner, I do believe because it's our protocol getting people up and getting them moving 2 to 3 hours after your surgery. And I think, to me, that's essential in preventing blood clots more than anything else. Aspirin came into vogue, then went out of vogue, and now is back in vogue again. And aspirin is one of the things that a cardiologist will tell you to take if you're feeling chest pain and having a heart attack. First thing to do is tell you to take an aspirin and get to the emergency room immediately. Well, aspirin does work, and it does prevent, and has shown to prevent blood clots in hip replacement surgery and knee replacement, and those studies are considered level 1 studies, which are considered some of the best studies we have. So and you don't always have to be on a very strong blood thinner, but what we do for all our patients is something called risk stratification preoperatively. We determine through a series of questions what's going to be the best blood thinner for you after that operation, and we put that patient on that blood thinner afterwards. I've been very fortunate also with hip replacement surgery, total hip replacement, never to have a dislocation either. And I think, again, it's because I think I guide my patients and tell them what I don't want them doing and what I don't want them doing, so that their muscles can heal and that they can get back to doing everything they want to do without any restrictions. So even I've had patients even fall, for example, and sometimes that's what we worry about, people getting up too quickly, getting lightheaded and falling, breaking around their hip or breaking their prosthesis. That can happen, and that can be a disaster, and that can be a problem. So that's one of the worst things that can happen. So getting your balance back, using a walker initially, and then a cane as soon as the physical therapist feels that it's safe to do so, is very, very important. And hopefully that answered your question.
Is COVID a problem at this time for the surgery?
So COVID has, obviously been, on the main concern for everybody in the healthcare community. I'm not wearing a mask, but I can tell you that everybody in this room who's assisting me is wearing a mask, and they're more than 6 feet away. I'm not wearing a mask so that you can hear what I'm saying, and it doesn't sound like this. But it is always a concern, and one of the things that we have been very fortuitous in having this separate orthopedic hospital we did this separate orthopedic hospital for multiple reasons that I talked about before, but one of the other reasons was to decrease the bacterial infection rate with joint replacement surgery, and we've accomplished that, and we've done a really good job doing that. By being separate from the main hospital, so that if you're having a hip replacement or a knee replacement, you're not recovering next door to somebody who just had a bowel perforation and has bacteria in their blood, and that nurse is taking care of that patient and taking care of you. Being a separate hospital, I think, has really given us an incredible luxury during this pandemic of not allowing anybody with COVID-19 or any bacterial or viral infection into our hospital. In fact, we haven't really seen that much of a dip in our total joint replacements or elective operations. In fact, over the past couple of months, we've actually been busier. We just had our busiest month ever in October, where we did more outpatient surgeries here at our CarePlex Orthopedic Ambulatory Surgery Center than we ever have since we opened up 10 years ago. And we've done more total joint replacements at our outpatient ambulatory surgery center this past month than we ever done so in the past decade. So the opposite is occurring. So more and more patients that are healthy enough are opting to have their joints done on an outpatient basis to be potentially away from other patients that might be sick with COVID-19. But I feel very safe and very fortunate to have a separate hospital where we don't have COVID-19 patients in this hospital.
All right, looks like the last question. Is there a length of time after a cortisone injection that you can have a joint replacement?
Yeah, so this is actually, there's been some recent literature that has come out with this. So what I was taught back in orthopedic training back in the 90s was that when you give a cortisone injection, cortisone inhibits our inflammatory cells. Next to our skin, our inflammatory cells are the second line of defense in preventing an infection. And if you give cortisone, therefore, into a joint, in theory, now you're inhibiting those inflammatory cells. And what was taught back in the 90s is that effect on those inflammatory cells can last up to 3 months. So what I used to tell patients from 1996 until literally last year, that you'd have to wait 3 months before you should have your joint replaced if it's been injected with a cortisone injection. However, I just did I just took a course on recertification. Every 10 years, orthopedic surgeons have to do their recertification process, and this is now my 3rd time going through my recertification process to be board certified. And one of the test questions and articles that were read that was a level 1 study now suggests that the effect of cortisone or any steroid in a joint is for up to 6 months. And the infection risk triples if you do surgery within 6 months of having a cortisone injection. So now I tell all of my patients who have bone-on-bone arthritis, who are somewhat reluctant about having their surgery, I tell them, if I give you this cortisone injection, and I just saw a patient about an hour before I started giving this talk, who I gave a cortisone injection 1 month ago. I told her 1 month ago, if I give you this injection, we have to wait 6 months before we can do a joint replacement surgery. And that's, again, trying to decrease that risk of infection. Because no matter what orthopedic surgeon you talk to, no matter where they are, they'll always tell you their number one perceived problem is infection with total joint replacement. Once you have a patient that has an infected joint replacement, you will never forget that patient or that case for the rest of your life, because it can be very problematic. Getting rid of that infection and typically warrants at least 1, if not 2 more operations to try to get rid of that infection.
All right, just one more question, and I'm gonna.
Okay, this is the last question?
Yeah, it's got to be the last question because we have to get out.
Okay.
About an hour anyway. Do you ever see an issue with the knee on the same side of a hip, like during recovery? This person's saying that they've had a hip problem and then they think it's creating a knee problem. Is that something you see?
Yeah, so sometimes what I have seen, and I see a lot of patients for second opinions, mostly for the knee, but also for the hip. And I can tell you that it's not uncommon for somebody to have their knee replaced. I look at the x-rays, I tell that patient that their knee looks great, but they're still having a lot of knee pain, only to find out that when I x-ray their hip, they're bone on bone on their hip, There's a nerve that goes from the hip down to the knee called the obturator nerve, and it's not uncommon for people that have what appears to be perfectly good knees that were done by another orthopedic surgeon elsewhere to really have actually hip arthritis, but that surgeon failed to get an exam of the hip and an x-ray of the hip to show that they had bone-on-bone arthritis. So that's very common, and vice versa. You can have somebody who had a hip replacement who's still complaining of hip pain when really it's their knee and their knee was never addressed. So I do try to look at the joint above and the joint below every joint that I see and examine them, because it's not uncommon to have referred pain. But it's not uncommon I have probably now 300 or 400 patients out there that I've replaced both their hips and both their knees. So it's not uncommon that if you have one joint that's affected, it can affect that ipsilateral of the joint on the same side, or it can start affecting the other side. But I also have some patients that have moderate degree of arthritis, and when I affect their bone-on-bone joint arthritis, the other joint actually starts feeling better because they're not putting all the weight or strain on that hip. And we can actually wait a little bit longer before we do hip replacement surgery until they do develop bone-on-bone arthritis. So I think that's all the time we have. Thank you so much. I look forward to seeing many of you out there. Come see me. All right, have a great evening. Thanks.